for the clinical design group today. So before we start, I'd just like to acknowledge the traditional custodians of the lands on which we're all gathered today. We pay our respects to elders past and present and extend our respect to all Aboriginal and Torres Strait Islander people, acknowledging the First Peoples as the first scientists, educators and healers. Just a reminder to everyone that we are recording today's clinical design group so that we can pop it up on our website and use it as reference for other written and online publications. Please, if you don't wish to be on the video, please turn off your camera, but otherwise you will be recorded. So for today's agenda, we will be doing a quick recap of the Sparked event in February in Hobart, and that's the leadership evening and the co-design workshops. And then we will be diving into the data group for AUCDI R4. So we'll have a quick kind of CDG AUCDI update and then go into the data groups. And we'll be looking a bit further into the functional information data groups and then also the clinical synopsis. So just for a quick reminder, if you are after more information around Sparked and AUCDI, you can obviously find it on our website. But the Australian Clinical Data for Interoperability, which is the AUCDI, is really specifying that what are the clinical requirements, what is the clinical information, that is the corresponding data elements and terms that should be included for data entry, data use and sharing of information to support patient care. And that is what we are doing here at the CDG. And on the other hand, the technical design group, they're working on the technical exchange specs, for example, AU Core, and that's really specifying how the core set of data that we've described in AUCDI should be structured, accessed and shared between systems. Just a reminder around AUCDI development. We have now just finished release 3, which was focusing on the chronic condition management encounter record and priority backlog. And AUCDI is an iteratively growing document. It's live, it's dynamic, and so we'll be working towards R4, release 4. So we might just quickly start off with a recap. So we recently in Hobart held a 2-day co-design workshop and a leadership evening. We had a really amazing turnout, the leadership evening and at the day 1 and day 2 of the co-design. I think it might have been our biggest yet. For the CDG, we had over 141 attendees. And for the AU Core TDG, we had 104, which was really amazing. And it was a really, really cool couple of days. So just a quick recap, the leadership evening was themed Bridging Islands, Sparking Innovation. Really big thank you to Blue Gum Health Transformation team who hosted us in Hobart, and we had about 200 people from all around Australia. Sorry, I think someone's not on mute. If they can pop themselves out mute, that'd be great. Thank you. We had over 200 people from across Australia, but we also had a visiting delegation from the University of Philippines, Manila, who were really interested in the work we've been doing and the how we've been doing it and how this community has really come together to support this process. So they were really interested to learn from us. And we had it was a buzzing room. It was great to see so many people. There were so many different conversations happening. And we did kind of also wanted to see, and I think this is just one of the mentee, to see how sparked were the attendees. And there were a lot of first timers, which was actually really amazing to see that. And we do try to move the leadership evenings around Australia so that we can allow more and more people, as many people to attend these things as possible. So it's great to see that was working. At the leadership evening, we had a plenary session which had keynote presentations from Daniel McKay from the department, John Lambert from Blue Gum, and then Mark Bronstein from CSIRO was talking about the rise of AI and what it might look like in the future for consumers as well as clinicians. And then we had a panel hosted by Kate Eberl, where we had software vendors, government and industry and GPs on that as well. So it was a really, really great evening. So then that takes us into kind of the meat of where we're looking at. On day 1 was the CDG and joint CDG TDG. So the morning part was just a CDG, and then the second half was the joint CDG TDG. So that was the spread of people in the room. And as I said, the day was split into two parts. The morning part was the chronic condition management part, and then the second half was that encounter record discussion. So I might pass to Tor now just to give a quick update on the first part of that day.
Thanks, Kylie. So yeah, the first part of the day we focused on the chronic condition management plan work that's been underway. So we did a bit of a recap of the journey of the chronic condition management plan activities so far. We had an update from around what the activities are that the clinical focus group have been doing. And then we also saw a demonstration of the GP chronic condition management plan minimum viable product. And then we did some mentees to get a sense from the group around what their thoughts were on that MVP that we presented. So if you jump to the next slide, Kylie. So this is a very busy slide, but basically it's just showing that timeline of the activities that have been done. I'm not going to linger on it too much, but basically just sort of showing where we started with the chronic condition management plan. We initially started talking about the workflows and what was required, and then that led to us, landing on creating this GP chronic condition management form as a minimum viable product to be able to demonstrate how the chronic condition management information could be captured and used in practice. And so at February, we saw the demo of what that is looking like based on the solution design requirements that we've developed, and also those baseline of the fields that are required for that minimum viable product. Importantly, on this slide, it's just showing that we are aiming to have this published by June 30. So that's a little star at the end that we're aiming for. If you jump to the next slide. So Charlotte Hesby, who's been part of the chronic condition management clinical focus group, actually gave an update on behalf of that group. So our thanks to Charlotte for doing that. And basically she just gave an overview of what the solution design requirements are looking like, and also what the required fields for the GP CCNP MVP, sorry about all the acronyms, is looking like as well. And then Charlotte also spoke to what the approach is that we've taken in terms of how we've developed that, which is that iterative approach where with the CFG, we've been sort of eliciting what those requirements are, discussing what those needs are for the GP chronic condition management plan, and then circling back with the group to make sure that we're capturing those requirements appropriately, and then including them in the form as it's developed. And then the last thing that Charlotte spoke about was just her experience of participating in that group, which was really cool to hear. Next slide, Carmen. So this is just sort of showing in detail what the solution design requirements are and what those baseline fields are. We're not going to show them here because they are obviously quite detailed, but when we publish this slide pack to the website, we will include those slides in. So if anyone wants to have a read through the specific solution design requirements, or in detail have a look at what it was agreed as those baseline fields to be displayed on the form, they'll be available there. So we're not going to go through it because it would take probably the entire meeting, but did just want to show that we have sort of captured that material, and it will be published in this deck when it's posted to the website. Next slide, please. So at a high level, what's included on the form is four key sections. So the patient details, the practitioner details, the clinical details, and the management plan. And then there are just on this slide some of the headings that are under each of those sections. I think the key ones that we want to obviously be aware of are having in the management plan sections the information around the chronic condition, the problems and needs, the goals, the interventions and actions, and the required services and treatments. So making sure that that information is captured appropriately on the plan and is available and is compliant with all of the MBS requirements and things like that. So if you jump to the next slide, Kylie, we've just got some screenshots of what the demo that Liam showed us at the Hobart event looks like. So in the SmartForm launcher, we were able to see sort of a rendering of what the GP chronic condition management plan could look like. So just showing in those sections the different fields that are required. And if you go to the next slide again, you can see here, where in the clinical details section for the problems and diagnoses, some information has pre-populated from the launching system. And then also in the plan section on the right there, you can see what it's looking like for the information around capturing the problems and needs and the goals. So again, this is not the demo in its entirety, but rather just, I guess, trying to show a little bit of what we saw when we were at the event in Hobart. So next slide, Kylie. The main thing after we showed the demo is we did do some mentees to get some feedback from the CDG around how useful is it to have this standardised MVP, and how useful is this as a starting point towards a shared care plan. The feedback in the mentee was that it was overall positive, but obviously acknowledging that it is just the minimum viable or minimum lovable product, and that there is a lot more work that's needed. And then the other mentee we asked was around what are the opportunities in having this MVP. The main sort of themes that came through, or the key ones that came through in the word cloud, were around, standardization, interoperability, having it be a starting point that we can build from, that it will support Medicare compliance, and that for consistency and research purposes, this will help to enable some of those requirements in the long term, obviously. And then the final mentee question we asked was around what usability features do we still need to consider or think about. And the top three that sort of came up were around having it upload to My Health Record as not just a PDF, but as an actual FHIR questionnaire, that we need to ensure that it's pre-populating with that standardized goal and intervention information. And that, again, this will probably be a longer term stretch goal, but having direct consumer access to be able to contribute into that form is highly desirable. If you go to the next slide, Kylie, I have included screenshots of what those actual mentees were in their entirety. So if anyone's interested, that's there for you. But yeah, I think overall the feeling was it's a good place to start, but we know there's a long way to go. So in terms of next steps, slide. What we'll be doing in terms of progressing this is really continuing to work with the clinical focus group to progress ahead of our next in-person event in May. So we'll be sending out some meetings to that clinical focus group by the end of this week, so that we can start those discussions again, or continue them, I should say. So we'll be focusing around what's needed to support the review workflow, because that is something that we haven't addressed in the current state of the MVP. We'll be also looking around what's the process that needs to, the process mapping for actually using the GP chronic condition management plan in practice. And we'll be also continuing to escalate any hairy questions or any of those things that come up that we know need to also be thought about in developing and using this MVP, but may not be addressed through this implementation. And then we will also be starting the process of submitting the FHIR implementation guide for the GP CCMP through the FHIR community process. So that's going to be a longer term activity, but it is one that we want to make sure that we're going through, so that we do get that community feedback on this form. We'll have a final draft to present at the May event, and then the May face-to-face event, and then ideally we'll be publishing the FHIR implementation guide for the GP chronic condition management plan by June 30. So that's sort of what we went through and where we're heading with the GP chronic condition management work at this point. So I think that's me done. I'll quickly pause or hand back over to Kylie. If there's any questions, feel free to chuck them into the chat.
And we acknowledge there are many, many acronyms, and we were just talking about how GP, CCMP, MVP, FHIR IG is a really, really long train of acronyms. So I know Tor's last minute rejig of the slide to try and not have such a long acronym soup. And I remember one of our very first meetings where Rob Hosking called us out on 3-letter acronyms and how we need to do less of them. Well, we've done less and we've made them 10 letters long now.
Yes, we've gone from having 3-letter acronyms to just 10-letter extended ones. So, Adrian, I can see you've got a question in the chat around tasks linked to specific individuals. I think that in the way that it's structured, we have tried to think through that, but I would have to double check and get back to you.
All right. And yes, we do have a date, Chris. Oh, yeah. Do you have a date? I can't think of it off the top of my head. I think it's 27, 28, but it is on the slides at the end. And we'll make sure to mention it, and we'll hopefully get details out more sooner rather than later. But yes, we do have dates and they are locked in. So you'll see them soon.
It is the 27th, 28th. You were right.
There you go. Yeah. 27, 28, 27th being the CDG, 28th being the TDG. Okay. All right, so then that kind of takes us to our joint session, and this was the first, it's definitely the first face-to-face joint CDG TDG, and it was really the objective. It was to do all of these things, but it really was bringing the TDG up to where we were. So as a clinical design group, we've been talking about encounter, reason for encounter record, encounter summary, all of these things for about 2.5 years now. But for the TDG, they haven't really had a chance to kind of have these conversations with us, and we do acknowledge some of them do come to the CDGs, which is really great. I can see a couple online now and really appreciate their attendance, but this was a real opportunity for us as the clinical design group to kind of share and express some of the things that we've been working on and bring it to the TDG. And I think Heath had a picture of like two science things colliding and exploding and, building something beautiful out of it. So that was kind of the theme of this. And it was really the beginning. Like we very much recognize this is the beginning of the discussions, and we know that we need to take it further. And that, it wasn't intended that any concrete results come straight out of this. This is the beginning that the TDG can take and run with it and then come back to us, and we can keep providing them our requirements as well. So the objectives of this session was to recap our CDG journey for the encounter record, to bring the TDG along on the journey, update on progress of the patient summary and encounter record clinical focus group, agree the encounter record MVP data group scope, as well as the data range scope, and then explore some usability requirements of encounter record. So much like the chronic condition management plan, this has been going on for a little bit. So we went through sort of where we started with reason for encounter and encounter modality within AUCDI, and the discussions that we've had over the last 2.5 years to get to where we are today. And I mean, what we started to think about is all of this encounter information and how important it is, and how it really does, getting it structured, getting it coded really helps us to enable that clinical decision support, analytics, operational reporting, population health analytics, statutory reporting, as well as the clinician to consumer or clinician to clinician consumer communication. But that encounter information, if structured and coded appropriately, can be then to generate what we're calling an AU encounter record, which could be then used to update a patient summary. So the slides that I haven't included is the updates from the CFG, and I might actually pop them in after so that they go up, but they included updates to the definitions that we worked on in November. So the CFG has been working on those, and they are currently draft. So we'll pop those up as well, but they haven't changed too much from where we started, but we started to think about what else do we need to help make those definitions make sense. And I think we'll talk a little bit about definitions a little bit later. So the other thing is really thinking about that now consumer journey, and how the patient summary that we've been working on and talking about for a little while now, how does that work alongside the encounter record? And we know that we want this patient summary available for access along a consumer journey, how an AU encounter record could help to provide that data to help keep that patient summary information up to date. Just in the context of the connected care journey that the government did, just showing a patient's journey through having an incident, going to ambulance, going into hospital, and then follow-ups, how can an encounter record kind of help to support that, and what that might look like in terms of a patient summary, a care plan, those encounter records, and then clinical decision support as well, and then all kind of feeding into population health insights, because we all want a learning health system. So that was a long introduction, but what that kind of did was then we set the scene of what does good look like for an encounter record. So we've been talking about encounter record for a while and some of the trauma and some of the problems that we've had in the past in trying to define this. So we had some consumers and clinicians talk about what does good look like for an encounter record. So Pip was there as our consumer, giving us consumer perspective and introduced us to the consumer charter and really showing us what they get as what consumers get versus what a consumer might want, and thinking about that clinician summary versus a consumer summary. Oliver, from the GP point of view, looked at how an encounter record could be useful for a GP caring for a patient long term, and when and how it would be useful and what it should contain. Kim was talking about how data needed to serve the clinician and the consumer, and really highlighting the problem around needing to have information available to the clinician or other carers when they needed it. And Darren was really talking about how information must flow in both directions, otherwise continuity breaks. So if the encounter is invisible to the rest of the system, then the onus falls entirely on the consumer to remember the details. And is that really right? The other thing that he was bringing up is, thinking about the future and thinking about the context of AI scribes and ambient tech. And, is the future really conversational? And do we need to stop thinking about search, and can we think about it as a conversation powered by AI? So the slides from all of these are on our website. So you just need to go to the Hobart meeting and you'll be able to find those there. So that took us to the workshop activities, and we're really focusing around that AU Encounter minimum viable product and thinking about the scope and then usability and functionality. So we'll sort of divide it into two parts. So starting with scope, we really need to determine the scope of that encounter record. So we're considering it from two different dimensions: the data content, the data groups, and the data range. So for data content, we're really thinking about what are the relevant data groups and specific data elements that should be included to support core common requirements of an encounter record to support safe clinical care. So what we essentially did was present the results of the work that we did at the November CDG workshop as a first draft for an encounter record MVP, and really asked, is this a reasonable starting point for the content that we need, and these were the results there. But we also asked, based on the discussions in the room, the discussions led by the clinicians and the consumer perspective, should we include any of the following in the encounter record MVP? And so some of the ones that had been identified around follow-up action plan, problem diagnosis to support that provisional working status, clinical synopsis narrative, some of these things, and there's a bunch of the things in the other that we need to go through, but these were the things that kind of came out. When it comes to data range, we were referring to what range of encounter data should be included for exchange. And when I was thinking about range, we know that there's different types of encounter information. There's encounter metadata, which is information about the encounter specific information, so things that were originated during that current encounter, so newly generated, updated, diagnosed, or confirmed things. Historical information, so patient history information that was identified by the service provider in that encounter, and then document and artifacts, so things like prescriptions and referrals and other things that kind of stand alone as their own thing, that are generated as part of the encounter. And what we really wanted to do was understand, what are we actually including for exchange? We know we obviously need the metadata. We need the things that happened during that encounter that was specific to that encounter, but historical information that was collected, is this useful to be exchanged? Yes, it is useful to be collected, but is it useful to be exchanged? So as part of the workshop, we provided a range of scenarios and consultation notes. There was a range, and we really thanked everyone from the CDG who were able to help us give us information to put into these consultation notes. So we did have GP, urgent care clinic, 1-800 Medicare, exercise physiologist, dietitian, paramedic. We had medical specialists and pharmacy. And what we asked as a group, we gave each group 2 encounter examples and asking to identify the different types of information contained with the examples, which data points should be included for exchange in that AU encounter record, and then what considerations around the exchange and access of the information. And then there was the pharmacy encounter scenarios where we know that data isn't recorded quite in the same way or at all compared to other encounters. So what what of those scenarios would there be information that's worth exchanging? So we haven't had a chance to go through the results in totality. So we will bring those back to the CDG when we're able to. But we did do some Menti results on the day, and it was really clear that it's not an easy thing. There was a lot of discussion, and it reflects in the Menti here that it isn't so simple. And I think the overarching catch cry of the afternoon became it depends. It depends on the context. It depends on the clinical scenario. It depends on who you're sending it to. It depends on all of these different things. And you can see there were some things that people did agree on, but there was a whole bunch of debate. And we acknowledge, and we were very aware that this is probably what it would be like, and it is an opportunity for us to start the discussions on, how do we start to break some of these things down. So for, I guess, a roundup for this workshop, we do know that the MVP data scope still needs some consideration, and we do need more consideration around the problem statement for the MVP. That first activity did identify data required for an encounter record. So even if it doesn't make it in, like we didn't agree on what the MVP looks like, we do know that those bits of information are of interest for encounter records. So we do want to add these to the backlog and start working through some of these. For example, that problem diagnosis specific data element, follow-up and plans is a big one, clinical synopsis or narrative, patient-generated device data, point of care test, family history. And I've put those stars in there just because they were like very highly rated. And then activity 2 around agreeing the data range. Very much it was some things are easy, but the rest it all depends. Some things like metadata, reason for encounter, or presenting a planar diagnosis seem to come up quite clearly, but then the rest, there was a lot of discussion, and we'll go through all of the worksheets and bring kind of a bit more detailed feedback at a future CDG. So next steps, as I mentioned, we'll bring back the results a little bit more in detail and have more discussions at future CDG. We probably will look at the scope a little bit more in the May face-to-face. But we will start to include some of the new data groups that were identified on the day as part of the AUCD IR4 as we can kind of start to slide them in. For usability, the second activity, we really were thinking about what function do we need. So to support clinicians and consumers to find what they need and when they need it. Knowing now current systems, we need to devise workarounds, we reuse fields, we prefix titles to make it easy. So if we're designing a new way of doing things, what capability does the features of an encounter record need to support? If we're starting to redesign this and thinking about it as a whole new thing, what do we want? And if we can have what we need right from the beginning, then maybe we don't need some of those workarounds. So if we're thinking about filtering and searching on provider organization, encounter details, dates, reason for encounter, what else do we need to kind of make it easier for us to find things? Chris Moy very kindly presented around, because I asked him what does good look like for him, and he kind of reinforced our need to make sure that our definition for encounter record needs to be relaxed and give us enough room to allow all the different real world use cases. We're trying to find a common language so that we know that certain use cases, certain contexts require more constraints or more specifics, but for us, we're trying to do something broad that can be reused widely. So we need to, dance and have a lot of space in our suit to kind of give us some room to dance. He also talked about how the difficulties in finding specific event summaries within a My Health Record document list and how we don't want to repeat that again, and the kind of information that he would like to be able to discover or find a specific document or information as quickly as possible. And he gave some of his elements that he was thinking about there. So I also presented really quickly some made up things about to help us think about where we could put filters on things. Things could be presented in a timeline view, which could be then clicked on to kind of delve deeper into an encounter record, or you could have a patient summary on one side, and then you could then delve into specific conditions or medications to understand, what encounter records might be related to that. So that kind of took us into the workshop where we were looking at what data points would we be required to search and filter on when interacting with an encounter record. And the metadata was highly prized or highly valued. And so you can see here, I think there were 18 tables. And so they found all of those really useful. We did also ask a mentee to see what would be the 3 most useful data points. You can see outside of the metadata that there is other things like diagnosis and procedures in there. And there was around considerations around, privacy, consent, currency, safety, things like that, sensitive encounters. The other part that we did ask too is what user interface or experience features will make an encounter record useful. And this was really interesting to see where people were going. I kind of grouped them roughly into 5 different categories: look and feel around accessibility, being able to have encounter and patient summary together, the flexibility to customize your own view, like that bespokeness for you, summarized views, dashboards, highlights, timeline views, and trend views. Being able to search and filter, that was a really big one, having flexible search, being able to sort, being able to be clear how things are filtered, and grouping of things, linkage and provenance, being able to have access so that they go from one to the other, linking related encounters and linking to source data records, access and use, allowing consumer amendments, and allowing encounter records to be consumed back into the SIS. And then the big one is AI support to help you create summaries, but also to support the search, whether it's through filtering or like a conversational layer asking the AI a question. And that was the mentee from the day as well. These were just some other considerations around data privacy and consent, data quality, I think trust, auditability, volume of data and noise. So knowing that some patients may have many encounters. So how do we find what we're looking for? Legislation, data ownership and provenance really came up. In terms of next steps, as I mentioned, we do need to do a bit more analysis of the results, and obviously those feed into TDG discussions as well. As this was the first CDG, TDG, we were really interested to see how people felt about having that kind of dynamic. We haven't really done that formally in person before, and I think we got some really good feedback, and people found it collaborative, informative, but brain draining, and I think that's pretty on par, so I'm pretty okay with that. But for me, one of the really great things about having that CDG, TDG opportunity right before the TDG was that the inputs and the feedback from that day were able to feed directly into the next day. And these were the objectives from that second day. The TDG held more like a discovery workshop where they actually really asked a lot of the same questions, but from a technical perspective. And they were able to bring the learnings from the previous day into this second day. And I won't go into this in any detail because just for time purposes, so time reasons, but they did a really great recap on the 5th of March in the AU Core TDG meeting, and you can find their minutes here, but you can also find a recording of it there. So if you're interested, please head over there. I think they had a really interesting day as well. And so that takes me to the end of the updates from the recap from the Hobart meeting. So I might just dive straight into it with the AUCDI and CDG updates. And Kim's just joined just in time. I'd just like to welcome Kim, our newest CDG co-lead. Thank you so much for taking this on. She's been involved with us for quite a while now, and really appreciate her enthusiasm and commitment to the Sparked program. So thank you for becoming one of our co-leads. Thanks, Kim. The other updates that I have in terms of AUCDI R3, that was open for comment. The comment period is now closed. Thank you so much to you guys, the CDG as a whole, as well as the digital health community for providing feedback. While it is closed, we do want as many viewpoints as possible. So if you do have any outstanding feedback, please get in touch, and we can have a chat about what your feedback is and if we can get it in, because we really do appreciate all the effort that everyone puts in to come to these meetings, but also provide formal feedback through the feedback process. So the content team is now reviewing our feedback, and we are looking to publish this in June. As usual, all feedback and Spark responses will be published on our website along with the document itself. The AUCDI design principles, we did present that, I think, at the last CDG or the one before. We've had that open for feedback on the website. We have received 14 responses. We will be going through those and then updating the design principles. And once we've done that, we'll obviously bring that back to the CDG. We still have the AUCDI criteria for things tagged core to go out for feedback, but because we had the AUCDI R3, we didn't want to kind of cross too much. So we'll probably look at putting that out soon, and we will do the same process. So that's the end of my updates, which was a bit of a whirlwind, but I kind of wanted to keep as much time available for the actual data discussion part of it. So for AUCDI, as I mentioned earlier, we have completed R3 or in the process of completing R3, and we are starting to look to R4. So for AUCDI R4, we really haven't done any real scoping activities yet. They will come either in the May or the July CDGs that are coming up. We haven't quite firmed up the agendas, but when we do, we'll make sure to let everyone know. In terms of R4 content, we don't know. We have a couple of things that we are holdovers from R3, which is assessment of function. And we know that the pregnancy stuff has come all the way from e-requesting, that's been a high interest one. And so there's been a little bit of work being done. So we'll eventually like to to present that to the CDG for inclusion within AUCDI R4, and also the encounter record stuff. So the things that came up in the CDG face-to-face, clinical synopsis, and some of these other ones we would like to include as well. In terms of the rest of the scope, I think it's all kind of open. It depends where the government goes, where you guys take us. We will talk about some of those priorities in the May or the July, but we will also be doing community pitches again. So this is an opportunity where you guys as the CDG can let us know what is high priority for you and see where the community sits and whether we should include it in R4. Once we are sure where it fits in the agenda, we'll make sure to let everyone know and give everyone an opportunity to present what is of interest to them. So watch this space. You definitely won't miss it. We'll make sure that everyone has enough notice to be able to prepare something if they've got some burning questions there. So for today, we are looking at the functional support requirements, functional impairment summary, and clinical synopsis. So I might now pass to Nairi to delve straight into the details. If you have any questions about that mountain of information that I have just dropped on everybody, please feel free to pop them in the chat or send us an email and we can follow up after. Thanks, Nai.
Thanks, Kylene. Hi, everyone. Yes, so we're going to jump straight into the data discussion now for AUCDI. And on the screen, you can see we're going to start exploring the AUCDI R4 proposal for clinical synopsis. And as Kylene mentioned, and we just circle back a little bit, when we're thinking about this, we're talking about how does it fit within the scope of an encounter record. So we're looking at a clinical synopsis to be able to support an encounter record as one of those potential data groups that we need to be able to support continuity of care, to clarify clinical understanding or communication, or to be able to support one or more care events. So on the screen, you can see we've got the data model down the bottom. The data group is clinical synopsis. There's a narrative data element there called synopsis, which supports the synthesis of a patient's health status and can provide clinical context in relation to one or more care events. The intent and purpose is to provide that clinical understanding and to be able to give that continuity of care. So we would use it as one instance within per event within a health record. And we've also got the ability to put the date and time of the assertion. So we can actually record the date or time when the clinical synopsis was asserted. The data model, for those who are unfamiliar or new to the CDGs, the data elements that are represented with the white background and the orange circle and white stars are the proposed candidates for AUCDI R4. And this is a complete data group proposal. So we'd be very keen and interested to have any thoughts or feedback you've got around the data group and open it up to the data group for discussion. Yes, I think Oliver, we've got a question.
Yeah, thank you. Now, I'm not sure if I wasn't paying attention closely enough. Is the synopsis intended to be something additional to our routinely made record for the consultation or other service that we're providing?
As like the encounter record, is that what you're...
Well, my question is, so we see a patient, we write down any symptoms, our examination findings, our assessment, what we think their problem is, and often we already know in general practice, we know before they even attend us, but nevertheless we record it, and treatment and so on. So that's the record we make routinely for our own purposes, for caring for the patient. So is the synopsis now an extra thing that we would have to do and other health professionals would have to do in addition to those routinely made notes?
I think, Oliver, it's not have to. I think there's no have to. I think this is if we want to exchange some narrative or we want to record it in a structured way, then this is how we could do it. And I think in the future, as we move towards more structured information where some of those things that you're recording in the problems, in the plan, in all of those things may sit in different places. This could be a place that you could put a consultation note. It could be where you might want to put in like an AI transcription, perhaps. It could be used for any sort of clinical synopsis or narrative. Heather, did you want to add or fix that?
Yeah, look, the kind of places where I see it used, Oliver, is often in transitions of care where you've got a whole lot of structured data and you actually want to go, here's the guts of it. Like I think of a referral letter, think part of a discharge summary where you just want to do the clinical nuance that needs to be text to actually provide the filler in between the gaps of all the structured data. So it's just a single place to allow for a summary of some sort in some kind of context that's relevant at this point in time. So it's a snapshot, if you like, of the patient. Think of it like a handover, the kind of thing you do as a verbal handover. That kind of thing is where it fits very nicely.
I was about to say, it sounds you're talking like a handover. And again, that same old question is, what is the purpose of it? Because if we knew the purpose, that would help to work out who would use it when and what.
It can be used in all these things. But, when you write a referral, you're always doing a little synthesis of what's been going on in say maybe just a single paragraph before you put problem lists and adverse reaction lists and medication lists and all that kind of thing. So it's labeling some of that kind of stuff.
So in that context, it's a concise statement of the reason for referral. And you're right, it's a kind of synopsis. Anyway, I'm interested in others' thoughts. I'm just trying to get a grip on what we think we would do with this.
It's meant to be incredibly generic and can be used in all sorts of contexts. So you could relabel it in terms of a referral with a particular style or something like that if you wanted to within the actual letter. But this is just a single place where we can get a clinician-generated synthesis of, the important bits, basically the highlights.
Chris.
Thank you. And thanks for the explanation, Heather, because that actually kind of helped me, because I was with Oliver, I was trying to figure out the use for it. But I think the answer is just saying is there's many actual use cases for it. It's not defined to single use. It may have use as a handover. It may have use as just a way for someone to structure the notes to say, God, this is so long, I just need to get an update there. Or it may be used, I can definitely see it being used for, automated extracting a lot of the information that is coded and then sticking it into a narrative clinical synopsis within the record. So thank you for that explanation. So I guess I say I don't have questions now. I just wanted to summarize that I had questions at the start, but by the end of your explanation, I don't now. Thanks.
Yeah, and the actual data model will have some more information which will be called use, and that's part of our standard process, which should include some of these kinds of things. And Kylan's example of where you might put AI-generated synopsis of the meeting might just go here because it's free text, not the structured bit. So that's something I've never thought of before, but it's probably quite useful. Kim.
So just adding to the discussion there, I wouldn't see this as a reason for referral. And to what Chris was saying, yes, it has multiple use cases, but my mind immediately went to a place where, in an ideal world, it's the first sentence of a referral. So it's like, hey, you know, okay, so I'll just read one that I wrote for a parent. It's like, I'm writing to you about Mrs. So-and-so for an assessment and management of suspected adult ADHD. And then the synopsis is she's a mother of one of my patients who's demonstrated highly suggestive symptoms. Like it's,
Yeah.
and I might also say she's the mother of 4 neurodiverse children. So it's like, okay, that sets the scene. Or it might be a 15-year-old boy with autism attending a specialist school who's in a single parent family, bereaved of their, you know, brother. And it's like, oh, okay, right. So it's, yes, you might be coming to me for an assessment. That's the reason for referral, but it's just a little kind of, it's the clue. It's like, this is the flavour of that person, is how I would, that's how I would use that data archetype, I reckon.
I think
that-
that's a lovely example.
Okay.
Kakyu?
Yeah.
Thank you.
Are there any other questions?
I work in the, I do a lot of work in the maternity space at a national advocacy level. So very keen, obviously, for that pregnancy state work to be done next, because that's a big part of our concern is the pregnancy health record being paper and having no digital tool to support that. But in this case, often in pregnancy, this would be really useful. So we often have an overarching pregnancy management plan. So, you know, key issues and then the plan for both management of that and delivery. And then we have all our underlying encounters every time they see a GP or midwife or obstetrician. So I think that overarching plan, this would be a great place to put that, to guide kind of ongoing care for a woman, and also to have that overarching plan be visible, no matter whether you sit inside or outside the hospital system.
Okay, thank you.
Mel?
Thanks. Hi, everyone. Just to clarify, is this where you see things sitting like maybe where you'd write to someone about maybe barriers that you're picking up on someone's recovery, or potentially, you know, 50-year-old mother, whatever the condition is, you know, expressing, you know, really intent on changing or has issues with willingness to change, or you'd put things like patient concerns around their care or a specific condition?
Absolutely.
Or they sit somewhere different. Okay.
No, this is the kind of thing. I mean, I think that's another version of what Kim was just kind of describing.
Yeah.
It's where you get to say that, where you get to receive or you get to send the highlights of the context of that patient that's relevant for this particular documentation or whatever that you're doing, whether it's a referral, other transfer of care, or some other kind of documentation, like the overarching plan for pregnancy. It's what are the bits that people need to see if you just get the you know, that very high level critical stuff that's not from structured data, or highlighting structured data that's a problem that needs to be addressed as a priority. It's that kind of nuance that we need as text, and we always need text to go alongside structured data in order to be able to communicate fully what we're trying to do. Because if we only do structured data, we often miss bits. This is the bit in between that actually probably gives the secret stuff that makes the difference in integrated care. Honestly, I think this is an important thing, even though it's a very generic structure. I think it's got broad reuse in all sorts of contexts.
Yeah. And I think it can be used quite, you know, in nursing, you know, when you're trying to communicate those summaries of the issues or the concerns in the, you know, that are used to support handover and those sorts of transitions of care. So, sorry, Andrew.
Just a clarifying point in terms of, I guess, within the CDA compliant discharge summary, there is a component called clinical summary, isn't it? And I was just wondering, is this, because I just feel like there is significant potential overlap between those, or is that clinical summary component specific to the context of a discharge summary?
Not knowing CDA specifically, I can't respond specifically, but I think this is, again, this narrative overview of what's critical for that discharge summary. I would use it in that use case. I guess we'd need to go and explore how that CDA segment is actually defined. But to me, it's again, whether it's introducing a referral, or it is the last minute things of these are the bits that are outstanding that we want you to do. It can be all of those things around what is relevant for this context for this patient, and discharge summary is another use case.
Yeah, it was just more in terms of, I guess, just because this sounds incredibly, that this concept sounds incredibly useful, but I'm just thinking in terms of, I guess, future-proofing in terms of sending, I guess, FHIR-enabled content to different, for different contexts. I guess how we would manage when there are things that are that could be interpreted by different people in a very similar way. Yeah, that so that would be my only comment in terms of if there's something that has already been sort of developed within the clinical summary space. Oh, sorry, as clinical summary, whether we just make sure that there is sort of clear definitions around when to use this and when to use that.
For sure.
Kim, last question.
Okay, so I'm just clarifying. I think it's different. I think this is the way I think about it. This synopsis would be the little spot where I can be messy and use like pretext to say to another human in the loop that this is what's going on. You just need to know that either the discharge summary might look the same, you know, or the clinical summary or what it might look the same for these two patients. But the thing that's unsaid that can only be expressed in a quick sentence that, you know, single parent, bereaved, whatever, that's where I think that would, and it's optional. I think you said to Frank's earlier point, this is not like we have to do it, but it's optional. So those other concepts that have been defined for summaries, etc., would, I don't know if they're optional or not optional, but I would expect them to always be there. But I'm always gonna, as the person receiving a patient I've never seen before, I'm gonna look for some clues about who this person is, if that makes sense. So I sort of see this data archetype as a little place where we can be human.
Yeah.
And put in free text that's not maybe yeah.
I-
Anyway, that's
yeah,
I'm just checking.
I
is
guess
that
it's just,
correct?
yeah, it's just the definition of synopsis is generally the
Yeah.
same as summary. So that was the reason why I
Ah.
just wanted to clarify.
Got you.
And-
Okay.
Yeah, and I guess to the point of when I said optional or otherwise, I think that, you know, that depends on the use case. We as part of AUCDI are saying these are optional, and these are like building blocks that can be used in different use cases for different things, as Heather has been talking about. But yes, maybe it might map directly to a discharge summary. But again, to Heather's point, we can't really say without being really intimately, you know, delving into the detail there. Yeah, and Avril. Oh, you're on mute.
Sorry, could we click back to the slide with the concept description?
One
Oh,
second.
is that possible? No, not possible.
Well, I don't know. It's a bit difficult for
Sorry.
some reason.
Sorry, this is with my GP hat on. I'm just wondering, we've used the phrase in relation to one or more care events in the concept description purpose. I'm just curious to know whether we need to use the word events, acknowledging, you know, the work with encounter record definitions and language there. I guess a lot of the use cases that have been brought up, they are related to either a specific event or maybe potentially a series of events, but also I think some of Kim's examples were talking about, I guess, more like the general care of a person, right, in terms of their family context, you know, neurodivergent children, etc., etc. So I just wondered about the wording, I guess, in that section.
So the notion of saying one or more care events is in some ways trying to counter the encounter issues. Does an encounter mean an episode of care as an admission versus a single event, and is an admission a single event? And we didn't want to buy into that. So it can actually be a summary of, you know, and obviously you'd have to provide that context, but this is about a number of events. I've seen this patient on 3 occasions in the last 3 months, or this is related to an admission which had multiple clinicians having care events within it. It's trying to stay agnostic to all of that and just be able to frame it in the context of the document, and you would say what it's in relation to in that, where it's relevant or not. So maybe we need to look at the wording around potentially, in the relation to one or more care events, but it depends. I mean, you're usually relating it to something as part of communication. It's not usually agnostic to any particular events and so on. So we can certainly talk around how we might enhance that if you can think of ways to make that better.
So I might call it here because I do want to kind of move a little bit and see where people are sitting. The Menti code to see. So essentially the question is, are we happy to include this in AUCDI R4? If you slight wording change, we definitely want to hear those, and please pop those things in the chat. If you have put in there around minor changes, please let us know what those are in the chat. Would be really interested to see what those are so that we can fold them in if we can. But also really keen to see where everyone else is sitting. So if you haven't already, if you go to menti.com and it's 15336497, otherwise you can scan the QR code there. How many people am I looking to look for?
There are 40 in the call.
40 on the call, okay. All right. So yeah, if you do have them any minor changes, please feel free to let us know. We are definitely interested to hear. Okay. Can definitely see some notes in the chat.
I would really like to see what the minor changes are so that we can try and address them, because I don't think it's been really clear to me that the issues in the discussion. So please put it in the chat what you think are issues.
Yeah, Andrew's popped something in there around clarification, so we'll definitely consider those things. But if there's anything else, please, because there is 7 people, and if you guys are all the people thumbs upping Andrew's comment, if that's what it is, that's awesome. If there's anything else, feel free to pop it in. So I might, it looks like generally we are accepting this. So let's go away, have a look at the minor word changes, and they'll probably turn up somewhere. Otherwise, I might move on if that's all right. Heather, are you happy with that?
Yep, it's good. Thank you.
Okay, let's close that one and somehow get back to my presentation. Oh, sorry. I don't know. It's just not working the same today. Okay.
Okay, so I want to just take your minds back to December last year, where we had a CDG and we were proposing the functional ability data group, which you can see in the middle of the group of 3 that are circled by the orange dashes there. And that was put forward as one of the data group proposals that's been submitted for community feedback as part of AUCDI R3. So that's one of the data groups that we've got there. But you can see on either side of that, we've got a functional impairment summary and a functional support requirements. And these are 2 data groups that are complementary to the functional ability. So when we originally proposed ADL, the activities of daily living, as a data group back in October, we started to unpack it and we realised that there were actually different components that needed to be discretely captured as structured data. So functional impairment summary was one of those, and functional support requirements was another one. So what you're looking at on this slide is how these collections of data groups actually complement each other. To the very left of the screen, you can see symptom signs. So what are those reported symptom signs or episodes described by the individual patient or caregiver or other party? We haven't actually got a data group for that yet, but it's on the roadmap and it's in the backlog, and we're hoping to have one of those very soon. And again, we're trying to bring that full picture together around, for those encounter records, or for those transitions of care, where we can actually have what were the symptoms of sign that the patient described, what's the problem diagnosis, so what diagnosis does the individual actually have, and then we've got this functional suite that we are then using to help support the individual's requirements to be able to function independently. So if we go to the next slide, please, Kylin. This slide is just a reminder slide. This is currently what's being proposed in the AUCDI R3 community consultation, so functional ability. It's around describing that individual's ability to carry out and participate an identified activity. So we would use one of these data groups as an instance per activity for each particular assessment. So above the data model that's sitting in the middle of that slide there, we've got in the orange box the concept description, and to the right of that we've got all of the different data elements that are described and defined. We've got ability that has got a value set, and also the difficulty which has got a value set. And these are aligning to the ICF and the FIM. I don't know whether people remember being on the call back in October where we used a set of possible 92 different tools to be able to bring this data group to life, essentially helping us to inform what is it we actually need to record in an electronic health record, and what is going to be useful and valuable to be able to support that transition of care or transitions of care for that person over time. So now what I'm going to do is hand over to Heather, and she's going to take us through a deeper dive into both the functional impairment summary and also functional reports support requirements. Thanks, Heather.
Thank you. This is one of my slides that I often use related to some of the broader modelling. And I guess I just wanted to bring that in at this point to kind of give a sense of, as we go on to this next stage, we are starting to develop our own data models that have not been developed elsewhere. And previously, a lot of the ability for us to be fast is because we've been leveraging existing models. And so this slide is kind of looking at what is currently out there, often in proprietary systems, at least, where the jigsaw is basically you've got all the pieces, but they're not terribly structured or terribly organised. And what we're aiming, and if you click next, Kylin, we're aiming towards getting that jigsaw on the right, where we get all of the clinical models working together, they fit together, they complement each other, they're not overlapping, and there's not big gaps, etc. And what we're using is an open standard called OpenAIRE that sits behind it. So this has got an ontology that helps us work out different structures for different types of data that we're recording in our system. So this is always sitting behind it. And then we're able to use that notion of, is this an observation? Is this some kind of summary statement? Is this an order? Is this an action where we're actually tracking that something is being done and completed? These are kind of basic structures that sit behind it and helps us to decide the concepts we model. So that's sitting in the background. It's got a robust ontology that sits behind it. So we're not just making stuff up out of thin air, if you like. There is a strategy and a methodology that sits behind it. Next slide, please. So this is starting to look at what some of our ecosystem is. Each of these hexagons with the names in them, these are data groups. The symptom sign one, as Nari said, is one that's coming. We've got health issue, physical assistance, health education, medical device, and today we're discussing the existing functional ability and these new ones called functional support requirements and functional impairment summary. So again, it's trying to do this jigsaw idea. We're meaning them to fit together, work together, complement each other. If we go to the next slide. This is where we've started to look and explore. Now, remember, this is not only coming from the OpenAIRE modelling. We had Katie, who was a physiotherapist working in CSIRO, presented to CDG on a couple of occasions, and she has been researching all of the tools that have been used in aged care around independence, scores and scales of assessments and so on. And so in the background, we've got 92 scores and scales that she collated and analysed, and we've been trying to distill the right kind of concepts that come out of it. But we're also wanting to sit it within this framework of all of the ecosystem, if you like, and how things complement each other. So at the top, you can see the symptom or sign, and the column there are various symptoms or signs that might be found with a patient, relating then to a problem or diagnosis that might then be come as a conclusion. And then this notion of the functional impairment being the loss or abnormality of a body function or body structure that limits their ability to perform activities or to function in everyday life. The functional ability is about a single activity and can they do it or not? And so that list in that column are the related ones going across the screen for the different symptoms, signs, then the diagnoses, etc. So we're seeing how they're all complementary but slightly different aspects of looking at how people are functioning. The final one is functional support requirements. So what do we need to support the individual, whether they're working independently or if they're in an aged care home and totally dependent, what level of assistance and what devices and so on do we need to support them to be able to do things like the transferring, like shopping, like going up and down the stairs, etc. So just to show that this was kind of testing the models to see how this works together. Again, just giving you context, the ICF is meaning International Classification of Function, so it's a WHO standard. SCT with those numbers, these are SNOMED codes, so we're seeing that these are also codable values that we can start to do consistently across these models. Next slide, please. So this is going back to, this is an update of a previous slide we had. We were given the task of how do we model functional status, all right? This has started us on the journey and no one's really done it in any systematic way except to use various scores and scales with everyone's pet flavour of how they want to record things. And often these things are kind of mixed up and munged together. We'll have ability and independence and assistance requirements in one score or scale, things like that. So we've got a history of being able to use these things, but they're often not terribly logical or thought out in this kind of way. So we are trying to deconstruct all of those 92 scores and scales to what are the bare bones things that we actually can record in our systems that could be used to autofill any of those scores or scales in the future, or to be able to take results from those scores and scales and bring them into our health records as generic agnostic data that we can use to drive decision support or AI or whatever it might be. So as Nari said, we've got functional ability. What is the individual actually able to do or not in release 3 that's about to be finalised? And we're currently today talking about functional support requirements and functional impairment ability. Now, we went from functional status to activities of daily living, right? And that was happening at an international level. The work that we're doing here has then started to drive it towards functional independence. And in the invitation that you got to come to this meeting, we said we're going to be talking about functional independence. That journey has changed over the last week or so, and it's turned into the functional support requirements rather than functional independence, because the independence and the definition of it and the way it's framed actually causes problems, because it's actually like a meta label or a conclusion, if you like. So we've taken it back another step to what does the patient need to get this stuff done, whether it's doing something like brushing your teeth right through to going shopping independently, or functional impairment being what are the underlying losses or malfunctions, if you like, of organs and systems that are limiting this person and able to actually engage with life fully. So next slide. So this is the functional impairment summary. So it complements, it's like another axis of how you would look at a problem diagnosis, but it's looking at what is that loss or abnormality that's affecting a body function or a body structure that limits their ability to perform activities or participate in life situations. So we're meaning, can they go to work? Can they go to school? Can they play sport? Can they actually just go and be social with a group of friends and actually communicate? All the way through to, you know, are they actually basically, you know, incontinence or whatever, those kinds of other things you'll find that are actually functionally causing problems for the individual. Sorry, getting tongue-tied here and just differentiating them. There's quite, as that table says that we've just seen, it is setting out the differences between them to test this, that it actually works. So we're starting with the impairment name. The orange ones are the ones we're proposing here. So I'm just going to skip over the ones that are the grey flags because they're proposed as future candidates and an extension in the future, although that's up for discussion today. So we're actually saying, we're showing you the roadmap We're showing you the orange ones that we think are in for this proposal, but this is up for discussion now. So the next one that we're proposing that's in the discussion is the severity, which is relating to the ICF, the International Classification of Function Values, no impairment through to complete impairment. The impact is a narrative that is about the impact of this particular impairment on the patient's life. So it's ability, again, to put something in that's nuanced around what the clinician or the patient potentially is saying about their impairment. We're not going to propose trajectory at the moment, which is the direction of is it going worse or better, etc., over time. But we are proposing the date of onset, the date of resolution, a comment, and which is just basically a narrative around anything else that's not in the structured data, and the date when this was last updated, so we know how current it is. We're going to move on to the next one, just because we're going to come back to talk about all of these together. So I want to talk to you about the functional support as well. So hold that in your mind, because we want to look at the ability, the functional impairments, and the functional support all together in a minute. So the functional support requirements then, again, the orange ones are what we're proposing. It's the activity name, and these activity names will be coded as much as we can, and we will have them consistent with what is the activity name in the functional ability. So there's going to be some correlation there. The support description, which is the umbrella term for everything they need for any kind of support. So that's a narrative. Then a description specifically about assistive devices. And those assistive devices are meaning any kind of personal tool, any kind of medical device, any kind of mechanical device, and even including support animals, all right? The assistive device details is where we could actually reuse our medical device data group here. So we've already got that, and we could use that to identify specific ones or specific brands if it's a particular medical device, etc. The human assistance type and the physical assistance type is about how we might need humans involved in this support. So assistive devices can be used with humans or without humans, but where we need some kind of human assistance, we can choose any one of these types. So we can have no assistance, which effectively means they're independent, even if they use devices. We can have supervision, we can have task preparation or setup, and we can have cognitive support, we can have physical assistance. If we choose physical assistance, then that next data element is then expanding on that to talk about the level of physical assistance, which is one or more people doing different types of assistance. So the standby assistance and light physical contact, that's something that some are familiar with, but I think many people may not be. I've put some definitions at the bottom to try and differentiate between the supervision of the human assistance type. So that's up in the human assistance type data elements, the second one, because that is about somebody looking from a distance to supervise, versus the standby assistance and the light physical contact is you're not actually doing the work, but you're right there ready to intervene should you need to at various levels of detail. So guarding is just standing by and not touching. The light physical contact is where you might have a fingertip on an elbow just to guide the person in the right direction, etc. Then we go into the number of people. So all of those things with physical assistance, we can actually define they need one person or they need 5 people or whoever it might be to help work out staffing requirements and support requirements and how you would schedule things if they're at home or in the hospital or in an aged care home. A comment, which is the additional narrative about any of the support requirements that's not captured in the structured data, and again, the last updated. So we were then going to look at the next slide, which is showing all of these 3 things together. And this is where we want to open it up for discussion. There's a lot in there, but I think it's really helpful to be able to see each of these 3 models alongside, because they're meant to complement each other, slightly different aspects of dealing with the same problem. I've been hearing that there's lots of pings in the chat, so that's good. But is there anyone who wants to ask questions, need clarification? Please, this is the time. Adrian. Oh, sorry. Oliver's there. Sorry.
Okay.
Yeah, thanks, Heather. That's all good. I was just going to go back a slide or 2, and only going to suggest that maybe the one before that, yeah, that logically, one might think that a functional impairment summary would come before you work out what the support requirements are. First, you need to know what the impairments are, then you work out what the supports would be.
We're not implying an order here at all. It's just
Okay.
two standalone things. So
All right.
I agree. And that's what we've done in the table. We put them in the other order.
Yeah,
but
that's good.
Slightly
Okay.
different. Good point, but it's not relevant for our point.
Sure.
These are standalone. You use them as you need it.
Okay.
Right. So sometimes you might need functional requirements, but you don't use the impairment. You go. All of
That's
that is
fine.
possible.
All right. Yep.
Adrian.
So my question is around the functional impairment summary. So you might have an impairment such as not being able to walk or paralysis of the left leg, and there's a whole lot of reasons why that might occur. And in order to work out what the impairment is and what the requirements are for that person, you need to sort of understand what the underlying cause of it, what the underlying causation is. And I'm just wondering how that's linking, because I can't see any linkage to a clinical diagnosis there. There may not be a clinical diagnosis, but if there is a specific clinical diagnosis, how's it going to be linked?
There isn't a direct link at the moment, but I mean, if we go to the next slide, which is that table again, we're certainly seeing that the correlation is that if you've got an esophageal stricture, then your functional impairment is you swallowing, etc. It is something that we need to think of. You know, is it something we can actually model is the question, or is it something that needs to be linked within the system as far as user interfaces and so on? And I think that's another level of discussion, certainly with the fire people as well, as to how you connect these things. And we haven't got it here for sure. If we start connecting everything through data models all the time, putting all of the possible, the clinical indications is one way we start to do it. But if we were to do that with impairment name and say related diagnoses, this starts to get very messy as far as all the possible linkages, and we don't want to define those linkages in the model. So I think this is a liminal area, if you like, that's somewhere in between. It's a bit of a grey zone. Yeah. I'm not sure that I think we're in a place to actually say this is the way we link it from the data models, but it should be working like that in a clinical system, that if you click on the impairment, you have the option as a clinician to point to a diagnosis. That's why we've got the separate models. But how that linkage would be done is outside of my technical expertise. I wouldn't want to promote it at the moment. If we decide that it should be done through the data model, it's something that we can do as an enhancement in the future for sure.
Thanks.
Kim?
Sometimes if I write it down, then I don't forget. So I had the similar question to what Adrian said, but isn't the reason for the difficulty, which is connected to the impairment summary, the impairment name, etc., isn't that captured in the functional ability, in that reason for difficulty?
That's about the difficulty level, though.
Sorry?
Right. It's relating to the data element above, which is the difficulty level, not the impairment.
Oh, the reason for the. Oh, I see.
Are you disappointed, or it makes sense?
Yep. No, disappointed. I didn't realise what the. I didn't know what reason we were talking about for what difficulty was.
Yeah, relating to the difficulty above. That's what the intention is.
And you're saying that you're saying that the impairment name, because I might say, okay, the impairment name, okay, I don't know, amputated leg, right? Doesn't have a leg from the knee, below knee amputation. Mm-hmm. That's separately in there, and we can't link it to a problem list that the patient might have. Is that the question that Adrian's asking? I
think Adrian was just asking that very thing.
Okay. So
at the moment, the data models are not intending to do that, because I think we haven't really thought this through. Maybe this is something that comes as a next phase. Maybe this is what comes out of today's discussion, or it's for a next release, or it's something that we think the vendors need to do as workflow and work smart sort of stuff. But at the moment, we're trying to keep them standalone so there's no overlap. All right. We don't want to have clinical indication in every single data group, for example, or it becomes onerous to document. Sometimes we do, where it's really clinically related, but we could have all of these kind of linkage points, and it gets, I think, a documentation burden that is just unsustainable as well. So we have to be a little bit careful about it. So the answer is I don't know, I think. Nairi.
Yeah, I think when we were unpacking this, we also thought about it not just as a one-to-one relationship. You know, you don't just have one problem that has one impairment, that has one support requirement that then demonstrates, you know, that an individual is able or not able to be able to do that particular activity. They're often that it's maybe one diagnosis or several diagnoses that overlap that then cause many or several impairments that then require different support requirements. So in terms of flexibility, we wanted to be able to just capture the essence of the clinical concept in its entirety, and be truthful to that particular clinical concept. And then we can actually represent the multiplicity of the different relationships between a problem diagnosis and an impairment, and then the support requirements can be represented when you're actually implementing the data groups at implementation, so on a UI. So yeah, it's sort of that thinking that we were bringing into this space when we were trying to unpack this. So yeah.
And I think Kath noted in there is, does the clinical description allow for this in the future? Is that somewhere we could put that kind of information if we wanted to?
It may, but I think it's not as specific as what people need, especially if we want to be using it for AI and that kind of thing. I think some of these connections and these linkages are going to be important, but I think it's also a technical issue that we need to talk about with vendors and get best practice around these kinds of things, rather than us assuming it can only be done through the data model. And that's something I think, you know, we should take on at some point. Adrian.
Could you add a free text field where a clinician could add something around what they think are the contributors to this impairment, but that's an optional field, so it doesn't have to be there, because obviously there are some examples of multiple causes, or other words, very clear what the main causes. So it might be a temporary thing, it might be a more permanent thing, depending on the nature of the underlying cause of the impairment.
That to me is what the clinical description is for.
That's not in at the moment.
Well, it's not in at the moment because you often also say, why do we have clinical description and comment? And so we actually said, Adrian says, we probably shouldn't have both. But if you want to have it here, because that's the place, it's describing the impairment and the nuance about the impairment. And that's what I would suggest would be put there. So if you want it in, we can certainly add it. But I have to say your name was mentioned because you're often mentioning.
And we were trying to just capture, you know, what is it that we need to absolutely support interoperability at this particular point in time. Like, we don't want to extend it out where there's unnecessary information in the data group. So, but the clinical description is where I would also describe more detail around the impairment as well. So yeah, sorry, Lloyd's got a question.
Yeah, it probably flows on from that. I was just wrestling with the whole space here where you've got episodic or changing conditions. So some psychosocial conditions wax and wane, and that one week the person will have very significant impairment. The next week they'll be fine. And so how would that be reflected in these codings? That would be very important to know.
That's, I guess, the trajectory, which is currently grayed out as a future enhancement as well. It would be giving you this idea that it's fluctuating. So we've got stable, improving, fluctuating, or known at this point. That would give you some sense of it's all over the shop, and that might be.
I just sort of feel that even if you don't bring in some of the others, to actually name it as fluctuating will help.
It is named as fluctuating.
No, but it's just the moment they're grayed out. So these are not to come through in revision 4. That's the thing that's worrying me.
Well, if you push for it, then we add it in. So we thought this was a secondary thing, but if you're saying that this is actually critical for your work, then it's a candidate, or it can be. That's what we're discussing.
In the disability space, I definitely see this as a problem where effectively you can end up with two quite conflicting reports. One was one day where a person saw the person and they were really fine, and then 3 days later they're actually in the midst of a problem, and their function is completely different. And that means funders and other agencies can make very, very obtuse decisions, which nobody who understands the person can make sense of.
That's a really good point.
So we can certainly bring it forward if there's a group that want to have it, if there's enough people, or even just one person that's strongly enough about it. Because you're in that world that when I'm not working in disability, if other people endorse that, then I'm open to it.
So I think this
There's
is
support
about
for it in the chat.
Yeah. So I think this is about scope, and it's not that we didn't want to do it. It was what was the natural first step. And I think we're coming back to Chris's, like, what was core of the core, and making sure that we don't design ourselves into a place where we didn't want to then have to go backwards because we've, generated tech debt because it wasn't quite right. So we weren't we were trying to make a first step, but if the call is like, no, I think trajectory is really important and we're really comfortable. The other part is the values as well. We need to be really comfortable. Are the values appropriate? And for us, if we need to make sure that, we're comfortable enough before we include it in R4. And sometimes that does mean needing a little bit more time. And so we would do the things that we're sure of first and then move to the next one. But if, this group here is really interested in trajectory and would like to have trajectory in, then and is comfortable with the values or can provide us with the appropriate values, we're definitely happy to hear it. I'm just wary of time. So Heather, we've got 4 minutes left. I wonder, do we want to just leave this discussion here and then we can bring it back to the next meeting? What would you like to do?
I think we should take it forward with the voting. I'd also just, as on the side, Lloyd, I noticed that you've made a comment about modified environment, and we've been talking behind the scenes around modifications or adaptations for support requirements. And I'm just curious if you want to give us a comment in the chat that might kind of give us some clues in there, or if we need to talk to you in more detail around whether that's an option as well that we should be considering.
So I was just picking up on what somebody else had mentioned in that context, because you broadened it. I mentioned in the reversion release 3, the medical devices, the structure has been built very much around a clinical environment and is used to using the terminology used by Therapeutic Goods Administration. Most of this stuff is actually in a different domain, but is Class 1 devices for TGA, and some outside the TGA, which have its own standard. But then we've incorporated things like assistance animals, which aren't mentioned. And somebody else had also mentioned, and it's a very valid point, that if you've got a person who maybe trips, you move them into a house that's got continuous path of travel. So that's a modified environment. Is that an assistive device in this context or not?
I think we need to have something that's separate around that, around the environment that needs to be part of the support. Assistive device in our definitions is not a TGA based one. It's not around formal medical devices, but it is including assistance animals. Not that we've got a model for how we name the breed and the name of the dog or anything yet, but
no, you don't need that. But it's just the flow on to the next point underneath that description is the details. Yeah. If the coding only goes so far and then you end up with this huge gap where you can't actually describe it, it's a bit stumped. Let's take it offline and see if we can work it out.
Our medical device definition, though, is much broader than the TGA definition. So it's certainly more inclusive of what you're thinking. Let's go to the vote, I think, Kylene.
Okay, so I've got 3 mentees. I've got one for the impairment, one for the support requirements, and then one for what other things. So if there are things, and as I said, this is kind of our first step. Like a lot of work has been put into this because this is we do know, like to Heather's point, that this is recorded in all different ways in different systems, and we're trying to find a common place to put it. So I will pop the so keep in mind I will try and flick between back and forth, but that's not necessarily easy to do right now. So the functional impairment model, as it was presented, let me just find.
So I think that it's good to get our feeling for this now, knowing that if we find there are major comments or major changes that we need to make based on what's in the discussion and so on, we can come back with a further enhancement at a later date, but at least we can start to take this forward.
We will go through the chat. We will go back through the chat and make sure that we've kind of understand what everyone's concerns are and all the commentary. So we will come back, and if we do, we may reach out to individuals around specific things. If you have popped in minor changes, again, please let us know what those things are. If it's not already in the chat, if it's already in the chat, feel free to thumbs it up or add it in again. Yes, everyone functioned.
So please put those minor changes in the chat so that we can track it and come back to it.
Yep, definitely keen to hear those. I might just for time quickly just move, please just pause for a second. Functional support requirements. No S on the support. Same thing, please. If you're any changes that you're interested in, if they're not already in the chat, please pop them in there, but we will backtrack. We won't, they're not ignored. We will kind of bring them out and read through them. Okay, it's looking pretty good though, Heather, like a lot of acceptance with changes, but we've had some really good chats. I think it's really promising.
It's good. Just to let you know that this is all going to be going back to the international community with Open Air as well. We had a chat with a small group of them last night, and we're going to be proceeding with all of those 3 models going through an international review, potentially multilingual as well. So it will then be happening in parallel with the kind of feedback that's happening in Australia. So if you're interested in participating in that, please let me know too, and I can point you to how to get involved in that.
Okay. And then I might just quickly move to the next slide, if that's all right with everyone. What other aspects of functional status should be considered for future AUCDI? So we know functional status is this really broad thing, and we've looked at impairment, we've looked at support and ability. If there's other things that we need to think about, whether they belong in the models that we've already presented, or if there's other things that sit outside of that, we're really interested to hear. So if you've got anything, please let us know. But while you guys are doing that, I might try and switch back to the slide just to go through the last few slides in the -2 minutes that I've got. Upcoming events. We've got one more CDG online in April on the 22nd. And then, as we mentioned before, there's a face-to-face CDG, TDG on the 27th and 28th of May. So the 27th is the CDG, the 28th is the TDG. For June, we are looking to publish AUCDI R3. There won't be a CDG meeting that month, but we are planning a face-to-face meeting in July. So that's kind of where it is. And just for note, some other events coming up. There's Digital Health Festival. I think that's in Melbourne on the 21st of May. We'll be at the CSIRO booth, and I think Kate will be on a panel discussion. We'll be at HIC 3rd and 4th of August, again, CSIRO booth, and we're planning either masterclass or workshop. The other thing to note is the SNOMED Business Meetings and Expo. They are actually in Sydney this year. There will be a Spark booth. We're also looking at having a Spark pre-conference workshop. It's currently an open call for abstracts. So if you guys are doing anything in the SNOMED space and want to put in an abstract or if anything with Spark, we're happy to kind of support where we can. Please reach out. But otherwise, I think those abstracts are open till towards the end of April. So check out their website. And then that's all I think I had. So thank you so much. I think that's all I had, and I was maybe going to flick to the Menti, but we will go and make sure we have a look at all of these. So thank you very much, and have a good afternoon, everyone. Thank you for your time.
Thanks, everyone. Much appreciated.
Thanks all.
Bye.
Thank you. Bye.